Thank you, Adiba, for the introduction. Also, I'd like to take the opportunity to thank the organisers of this forum for the opportunity to speak to you today about mental health support for people living with HIV. I'm just going to try and go back a slide. So I'm the Director of Research at ANFA's Treat Asia programme, based in Bangkok. And for those that don't know Treat Asia, it's regional research, primarily a research-focused collaboration that includes hospitals, clinics, civil society organisations, academic institutions, focused, as I said, primarily on HIV-related research, but also with education and policy-related activities. So I'm not a mental health care provider, so the focus of this presentation is not specifically on mental health related clinical care, so apologies in advance for those that were expecting a talk that focused on mental health clinical care. But what I will be covering is the prevalence of mental health and substance use disorders amongst people living with HIV, information and data on the risks or impacts of mental health and substance use disorders amongst those living with HIV, focusing on both HIV and non-HIV related risks and impacts, and highlighting associations between mental health and substance use disorders and the HIV care cascade. I'll also be talking a little bit about addressing the burden of mental health and substance use disorders amongst people living with HIV, and wherever possible, highlighting research and data from the Asia-Pacific region. But first, a little bit of the context around which we're having this discussion around mental health and substance use disorders amongst populations living with HIV. We heard this morning from Brigitte and others about how perhaps some countries in the Asia-Pacific region are lagging behind in terms of access to combination antiretroviral therapy, for example. But overall, expanded access to combination antiretroviral therapy, increasing rates of antiretroviral therapy coverage and virologic suppression has shifted the focus towards the management of HIV as a chronic condition and the need to better address and manage chronic comorbidities amongst those living with HIV, and to assess and address other measures of health or well-being, so for example, quality of life and functional ability. So why is it important to provide mental health related support to those living with HIV in the Asia-Pacific region? Well, the first reason is that mental health and substance use disorders are a very prevalent comorbidity amongst Asian PLHIV. Asia-Pacific data indicates depression, anxiety, or psychological distress prevalence rates of 3 to 60%, depending on the specific study population being assessed, the methodology of the study, and the mental health or substance use disorder screening tool used by the study. And Treat Asia network studies also indicate high rates of mental health and substance use disorders amongst both adult and adolescent PLHIV populations. So this data from Treat Asia's Substance Use, Stigma, Depression and Disability, or S2D2 study, conducted amongst over 860 adults living with HIV at 5 clinical sites within the Treat Asia network, found moderate to severe depressive symptoms in 19% on PHQ-9 screening. The study also found that 19% had recent suicidal ideation as defined by a PHQ-9 question 9 score of greater than 1. And these are rates of depression that are largely consistent with the regional research amongst similar study populations and using similar depression screening tools. Substance use data from the S2D2 study indicated very high rates of either ever using a substance or recent use of a substance, so particularly tobacco, alcohol, cannabis, amphetamines, and sedatives. 80% of study participants had ever used at least one substance, and 64% had used at least one substance in the past 3 months. Of those who had ever used at least one substance, 62% had moderate to high risk assist scores to any drug. And assist is a alcohol, smoking and substance use screening tool developed, I think, by the WHO. And again, these high prevalence rates of particularly tobacco, alcohol, cannabis, and amphetamine use are consistent with those found amongst other studies in the region. This Treat Asia analysis, looking at 150 adolescents living with HIV at two pediatric HIV centres in Thailand of median age 19 years old, found that at baseline, 11% had significant depressive symptoms, 7% had anxiety, and 14% suicidality, as defined by recent suicidal thoughts or having ever contemplated or attempted suicide. The study also found that just under 19% had hazardous or harmful alcohol use, as defined by an audit screening score of greater than or equal to 8. Addressing mental health support to PLHIV populations is also important because mental health and substance use disorders commonly co-occur amongst those living with HIV. In an analysis of over 120,000 adults living with HIV in a North American cohort, mental health multimorbidity, as defined by greater than or equal to 2 concurrent mental health disorders, affected 24% of the study population. If we look at those with a diagnosis of depression, we could see that whilst 47% of those with depression had only a diagnosis of depression, 53% had depression combined with another mental health disorder. Amongst those with anxiety, only 18% had just anxiety, but 82% had anxiety combined with another mental health disorder. 69% of those with bipolar disorder had bipolar disorder combined with another mental health disorder, and 92% of those with schizophrenia had schizophrenia combined with another mental health disorder. This Treat Asia analysis from a couple of years ago, looking at amphetamine-type stimulant, or ATS, use amongst over 1,400 Thai men who have sex with men and transgender women of median age 27, not only found high rates of ever using or recently using amphetamine-type stimulants, but also found that amphetamine-type stimulant use was associated with other substance use, so tobacco and alcohol, and mental health disorders, such as anxiety, depression, and post-traumatic stress disorder. It's also important to address mental health support to those living with HIV, because mental health and substance use disorders can negatively impact HIV cascade outcomes across all stages of the HIV care continuum. So globally, mental health and substance use disorders have been associated with increased risk behaviours and higher risk of HIV acquisition, delayed HIV testing, delayed linkage to HIV care, poor HIV care retention, delayed antiretroviral therapy initiation, poor antiretroviral therapy adherence, and lower viral suppression. But what does Asia-Pacific data show us in terms of the associations with mental health and substance use disorders on some key HIV cascade outcomes? Asia-Pacific data on the association between mental health and substance use disorders and HIV care retention is somewhat limited and mixed. So whilst the 2018 systematic review identified active substance use as a primary predictor of poor retention in HIV care and psychiatric illness as a significant predictor of poor retention in HIV care, none of the 3 Asia-Pacific studies included in the review identified mental health and substance use disorders as a predictor of poor HIV care retention. Contrast this to, for example, smaller studies, including those amongst adult PLHIV in South Korea, that found that those with depression were more likely to miss HIV clinical appointments. The global evidence base on the association between mental health and substance use disorders and suboptimal ART adherence is particularly strong, and substantial Asia-Pacific data confirms this association. So, for example, the S2D2 study that I mentioned previously, conducted by Treat Asia, found that suboptimal adherence was associated with moderate to severe depressive symptoms and moderate to high-risk substance use. And indeed, a wide variety and range of studies from the Asia-Pacific region have found that mental health and substance use disorders are associated with or a predictor of poor combination antiretroviral therapy adherence across different and diverse PLHIV populations. If we look now at the association of mental health and substance use disorders and HIV suppression in the Asia Pacific, again, the data is somewhat limited and somewhat mixed. So our S2D2 study found that moderate to severe depressive symptoms or moderate to high-risk substance use were not associated with a viral load less than 1,000 copies, whereas, for example, a study of male PLHIV in Thailand found that non-injection substance use was associated with a lower likelihood of undetectable viral load. Mental health and substance use disorder support of PLHIV populations is also important because mental health and substance use disorders are associated with other negative outcomes, for example, disability and reduced quality of life. And this is supported by an increasing body of regional evidence. For example, a study of older PLHIV in China has found that depressive symptoms account for a higher prevalence of frailty amongst the study population. And studies of adult PLHIV in India have found that those with severe depression experience 2.7 times poorer quality of life compared to those without depression. This analysis of the 753 S2D2 study participants that screened positive for either depression or substance use found that an increase in mean WHO disability assessment scores was indicating greater disability, and a decline in mean quality of life scores indicating poorer quality of life was found with increasing severity of depressive symptoms. The analysis also found that mean quality of life and WHO disability scores displayed a trend of greater impairment amongst high compared to low risk substance users. So given this burden and potential impact of mental health and substance use disorders amongst populations living with HIV in the region, how are we doing in terms of delivering mental health care services to them? And the short and very rapid answer is not particularly well. There's very limited integration of, for example, mental health screening in HIV clinical settings in the region. A 2018 assessment of mental health and substance use disorder screening and management practices and capacities across 95 HIV clinics in the international epidemiology databases to evaluate AIDS or IDEA collaboration included 28 Asia-Pacific sites across 8 countries in the region. And amongst these Asia-Pacific sites, 43% reported screening for depression, only 11% for post-traumatic stress disorder, and only 29% for other mental health disorders. And these were amongst the lowest rates of mental health and substance use disorder screening across the IDEA collaboration. A more recent IDEA site assessment conducted in 2020 across 223 HIV clinics in 41 countries found that alcohol use disorder and substance use disorder screening using a validated screening instrument was conducted in only 16% and 6% of Asia-Pacific sites, respectively. Again, amongst the lowest rates of substance use disorder screening in the IDEA global research collaboration. There's also limited integration of mental health treatment in HIV clinical settings. This data is also from the 2020 IDEA site assessment and shows that across the IDEA global collaboration, only 46% of sites reported screening and counselling for depression, and only 36% of sites reported providing screening and medication for depression. And if we look at other mental health disorders, such as anxiety and post-traumatic stress disorder, these proportions are even lower. So only 13% of sites reported screening and providing screening and counselling for anxiety. Only 11% of sites provided screening and medication for anxiety. Only 11% of sites again provided screening and counselling for PTSD, and only 8% of sites screening and medication for PTSD. Now, in this analysis, Asia-Pacific specific data is not available, but the analysis did find that screening plus counselling and screening plus medication were least commonly reported amongst lower and middle income country sites compared to higher income country sites. There's also limited integration of substance use treatment in HIV clinical settings. So this data on the reported availability of alcohol and substance use treatment amongst HIV treatment sites in the IDEA collaboration, again from the 2020 IDEA site assessment, found that of those that reported screening for alcohol use disorders using a validated instrument, only 29% provided on-site counselling, only 23% provided brief interventions or psychotherapy for alcohol use disorders, and only 11% pharmacological treatment. And these proportions are even lower for other substance use disorders. So only 9% providing on-site counselling for other substance use disorders, again 9% providing brief intervention or psychotherapy, and 5% pharmacological treatment. Linkage to mental health related care is also a challenge in the region. This analysis of over 320 adults living with HIV in care at the University of Malaya Medical Centre's HIV clinic found that of the 76 participants who had severe or extremely severe symptoms of depression, anxiety or stress, only 32% received a psychiatric referral. And this poor state of affairs in terms of the limited integration, the clinical integration of mental health and substance use disorder services in HIV clinical settings is in spite of provisions for integration in HIV treatment guidelines. The WHO HIV treatment guidelines from way back in 2016 outlined that the assessment and management of mental health problems should be included in the package of HIV care services for individuals living with HIV. That those services should include screening for mental health and substance use disorders and the provision of appropriate psychosocial counselling and support, and that these services should be provided at various stages across the HIV care continuum, either as an integral part of HIV care or through linkages to mental health services. The limited integration is also in spite of the increased availability of regionally validated mental health and substance use disorder screening tools. So S-Beta is a prospective Treat Asia study that's assessing suicide amongst adolescents living with HIV at 3 sites in Thailand. And the first year of this study focuses on the cross-cultural adaptation and psychometric validation of various mental health and substance use disorder screening tools. Analysis associated with this validation have found that Thai versions of the Generalized Anxiety Disorder Screening Tool, Audit, and the Columbia Suicide Severity Rating Scale had acceptable to good reliability and face and content validity amongst a Thai adolescent population. Treat Asia is also supporting validation of other mental health and substance use disorder related screening tools. So one is the electronic mental wellness tool, or the EMW tool, that we are supporting validation of in Thailand, Malaysia and the Philippines under a broader mental health and HIV integration study. The EMW tool is a 13-item mental health screening tool developed by Milton Weinberg and colleagues at Columbia University, and allows for identification of those screened into one of a number of categories of having either common mental disorder, a severe mental disorder, such as, for example, schizophrenia or bipolar disorder, alcohol use disorder, substance use disorder, or suicide risk. Limited integration is also in spite of some regional evidence on the effectiveness of both pharmacological and non-pharmacological interventions in the Asia-Pacific region, including group interventions, telephone-based behavioural therapies, brief cognitive behavioural therapies, and home-based social support interventions. So that's what we do have. We do have effective screening tools, we do have effective interventions, but what we don't have in the region is adequate funding and human resources for mental health care. So this graph shows government mental health expenditures per capita, and you can see clearly that the Southeast Asia region and the Western Pacific region fall amongst the lowest of WHO regions in terms of levels of government mental health expenditure per capita. And this data in this graph shows the mental health workforce per 100,000 of the population. And again, particularly for the Southeast Asia region, you can see that that numbers of the mental health workforce per 100,000 of the population are amongst the lowest of any WHO region. And this applies to mental health services in general and not just those specific to populations living with or affected or at risk of HIV. So in addition to more adequate funding resources and human capacities and resources, further integration of mental health and substance use disorder services will also require regional research on optimal integration models and strategies. In a recent systematic review of interventions and approaches to integrating HIV, mental health or substance use services, none or very few eligible articles are from the Asia Pacific. So this lack of regional research is at least probably in part to a lack of regional implementation research capacity, and indeed the importance of implementation research to inform the integration, adaptation or scale-up of mental health and substance use disorder services within HIV care is being increasingly highlighted. Some integration approaches that warrant further local assessment include task shifting or the delegation of care delivery to less specialised healthcare workers, such as peers, lay health workers, counsellors, or community-based persons, and also stepped care, whereby mental health intervention intensity is matched to an individual's treatment need and severity of mental health issue. Treat Asia's Chimera program is an NIH-funded program that aims to address some of these regional research gaps by developing HIV and mental health implementation research capacity in 4 countries in the region: Thailand, Cambodia, Malaysia and the Philippines. Some of the 16 fellows, the participants in this capacity development program, are working on generating implementation research on various HIV and mental health integration approaches. And the example I'd like to give is from Rena, who presented last year at the AIDS conference and at APACC, her work on assessing task shifting of depression screening and linkage to care to peer healthcare workers at the Tangerine Clinic based in Bangkok. And her analysis found that integration of peer-led mental health services was both feasible and acceptable to the patient population, but also the healthcare workers involved. So that's just an example of the type of research being generated by this program. So in summary, mental health and substance use disorders are a very prevalent comorbidity amongst Asian people living with HIV, with potential negative impacts on HIV cascade and other key outcomes. We have effective mental health and substance use disorder screening tools and interventions, but we lack adequate funding and human resources for mental health care, and there's a specific need for further local implementation research to inform integration, adaptation, or scale up of mental health services in HIV clinical settings. And I'd just like to conclude this presentation today with a little caution against viewing mental health support as part of a fourth 95 to be addressed either at an individual or population level sequentially following diagnosis of HIV infections, following the initiation of antiretroviral therapy, and achieving HIV viral suppression. Mental health and substance use disorders compromise continued HIV treatment cascade gains and achieving 95, 95, 95 targets and the goal of 0 new HIV infections. And as Robert Remian and colleagues suggested back in 2019, it's going to be impossible to significantly bend the curve and approximate an ending of the HIV epidemic without drastically altering our approach to diagnosing and addressing comorbid mental health and substance use problems amongst people most vulnerable to HIV. I'd like to acknowledge the US National Institutes of Health as the funder for the IDEA Asia Pacific Consortium and much of the Treat Asia research presented in this presentation. These are my contact details should anyone wish to reach out with any questions on the research data or issues presented and not have time to do so in the question and answer session after Grace's talk that follows mine. So thank you very much for your attention.